Okay. Dear Professor Mebaza, dear Dr. Arenia, dear colleagues, I'd like to welcome you all to my presentation about the question which patients undergoing non-cardiac surgery should receive active surveillance for perioperative myocardial injury or infarction. So let's have a look at patient number 1. This photo was taken a few years ago, in 2007 to be accurate. And let's assume during that time that this patient had an accident and has to get a surgery. And let's have a look at patient number 2. It's a slightly older patient who has to get a lower extremity bypass surgery. So who would screen patient number 1 for perioperative myocardial injury or infarction? Please raise your hands. And who would screen patient number 2 for perioperative myocardial? Of course, I showed you 2 very illustrative patients. In a daily routine, lots of patients are somewhere in between. And since we have limited resources at a hospital, it's important to find out which patients have at least a moderate likelihood for the development of a PMI. Current guidelines are not very clear whom we should screen, and that's why we wanted to provide precise estimates for the incidences of a PMI for A, specific patient profiles, and B, specific surgical disciplines. So we draw our data from the ongoing prospective and multi-center cohort study, and we included either patients starting at the age of 45 years with a history of coronary artery disease, peripheral arterial disease, or a history of stroke. And we also included patients 65 years or older, irrespective of their medical history. We defined any PMI as our primary endpoint, and for the statistical analysis, we calculated the incidences with their corresponding 95% confidence interval. And in order to justify the resources a hospital uses to screen for a PMI, we assumed that the incidence for a PMI has to be at least 10%. So at the end, we included 9,460 patients, out of which 13.2% developed a PMI. The mean age was approximately 74 years, and 44.2% of the patients were female. So on the left side, you can see all patients with an established atherosclerotic disease, and on the right side, we have patients starting at the age of 65 years or older without an established atherosclerotic disease. We defined this term as either a coronary arterial disease, a stroke, or a peripheral arterial disease, as you can see in the black frames. The red dotted lines show you the threshold we chose of 10%. I'd like to name 3 findings. First of all, you can see that as soon as a patient has an established atherosclerotic disease, the incidences for any risk factor rise. Secondly, chronic heart failure has the biggest impact for the development of a PMI. And thirdly, the more the age increases, the higher the incidence for a PMI gets. Here you can see in the red area we have all incidences for a PMI that are 20% or higher, and the green area shows us all incidences for a PMI that are under 10%, and orange is everything in between. And here I want to point out 2 things. First of all, you can see that patients between 45 to 60 years with an established atherosclerotic disease have an incidence of under 10%. And the same thing you can say about patients between 65 to 70 years without those comorbidities. And as I told you before, we also wanted to look at the PMI incidences for patients by surgical fields. And we could clearly see that thoracic surgeries have the biggest impact to develop a PMI after surgery. And it's also pretty interesting that when we look at the patients without an established atherosclerotic disease, if they undergo a procedure in urology or have a visceral surgery, these incidents are rather low compared to the other surgical fields. I'd like to name two limitations. First of all, we don't have a control group for the patients between 45 to 64 years because we only included patients in this age group with an established atherosclerotic disease. And secondly, the use of the threshold of 10% is of course very arbitrary, but our main aim was just to give a point estimate and then let the hospital or the treating physician decide at what point they want to start a screening or an active surveillance because, as I've said before, because of the limited resources. So I'd like to draw our conclusions. First of all, we could show that PMI incidences of under 10% are in two age groups. This is in patients between 45 to 60 years with an established atherosclerotic disease, and for patients between 65 to 70 years without those comorbidities. And chronic heart failure seems to have a big impact for the development of a PMI. And also surgical fields can influence the occurrence of a PMI. As I said, thoracic surgery is very, takes the first place. Also we could see that procedures in urology and visceral surgeries, that these specific fields are, have an incidence of under 10%. So I'd like to thank you all for your attention, and I'm happy to take questions.
Very good, Samantha. Any question? I may start. Oh, go ahead, Veli-Pekka.
Yes, Veli-Pekka Harila from Helsinki. Thank you very much for this informative talk, and I think very clinically important. When you say that chronic heart failure patients has elevated risk, they have the incidence of, let's say, 30% of what you showed. What does that mean? Because they have all the other comorbidities as well. So heart failure patient has coronary artery disease, maybe atrial fibrillation and so on. So how could you say that this is just chronic heart failure?
Of course, you're right. I guess a lot of other risk factors come with chronic heart failure. But as soon as you have a patient in front of you, it's important to note as soon as you know in the medical history that this patient has a chronic heart failure, you know that this patient has a very high risk of developing a PMI. What you're saying, I guess, for the study we did, I guess these numbers are not enough to explain why this is. I guess we should do a regression model to see if what factor has more impact and which one has less. But this study is more descriptive. Yeah.
Samantha, I would like to ask a question on cancer. There is an increasing recent literature showing that patients operated on for cancer have a very high risk of cardiovascular disease, not only related to age, etc. There are probably link between having a cancer and being at risk of cardiovascular disease. Did you see this in your cohort? I think in addition to, because you said thoracic, etc., maybe you should also look on cancer surgery.
Well, we only have data for patients who had surgery because of cancer. So I guess we have a bias in our data. because we don't have any data if the patient was operated with cancer. But when we compared the patients that were operated because of cancer, we didn't see a significant difference. Yeah. Thank you.
Last question from Detroit.
Oh.
Short question, short answer.
Actually, it's day trois. I'm just joking. No, thank you very much. My question was, if you know that chronic heart failure is associated with increased incidence of perioperative myocardial infarction, do you think it's because the patients aren't hemodynamically optimized before the surgery? You talk about treatment after. What about treatment before? You know they're at risk, so should they be better evaluated, better treated before they go into surgery rather than identifying them later? Because I assume in a lot of those it may be supply-demand mismatch or something else. And so where they start is important when they get the insult of the surgery on top of it, I think.
Yes, I think you're very right. I mean, I hope that the anesthesiologist who see the patient can figure out how bad if the patient is in acute heart failure. I guess one problem is with urgent and emergency surgeries. There, you can't really optimize the patient, but for every elective surgery, I think you're right. Yeah.
Yeah, I'm not sure the anesthesiologist can always do that.
That's true, yeah.
Okay, thank you very much.